So again, sodium is the major extracellular cation. Usually when you have changes in sodium in your blood, so if you have hyponatremia or hypernatremia, it doesn't represent actual changes in your body's sodium most of the time. Usually hyponatremia is reflective of some sort of dilution going on. So hyponatremia often is related to excess of free water or excess of free fluid, so it's dilutional. Hypernatremia is the most common cause, particularly in elderly patients, debilitated patients, nursing home patients, is dehydration, because they're not able to ask for water or they're not able to respond to their own thirst reflex, so they're not able to get up and get out of bed and get their own water. So the sodium concentrates because of the loss of free water. So there are several causes of hyponatremia. Both low and high sodium are divided into hypo, U, and hypervolemic, and hypo or hypernatremia, which you can tie your tongue very quickly if you say it too fast. So hypovolemic hyponatremia represents a total loss of both water and sodium. So generally excessive sweating, diarrhea, or your hallmark, of course, would be diuresis, is the most common causes of these. Euvolemic hyponatremia is more related to SIADH, so I briefly described what that was in your lectures. It is something to know about. It can be a pretty significant and severe disease state. It's related to excessive, inappropriate release of ADH, which is antidiuretic hormone, also called vasopressin. Any of those names may be used. It's released from the pituitary. It can be caused by cancer, patients with pulmonary disorders. It can even be caused by nausea or pain. This would not be a full-on ADH, but it would be some degree of ADH release, which could potentially lead to hyponatremia. If you think about, especially in my world in the ICU, how many patients have nausea and pain in the ICU? Probably nearly 100% of them, right? So you may have some degree of this going on in a pretty significant portion of patients. And what ADH does is, in the collecting tubules, it causes the insertion of aquaporin into the collecting tubules, which allows free reuptake of water. It allows water to freely pass from the renal tubules back into your bloodstream. And no sodium goes with that, which is abnormal. So you freely reabsorb your water, and you concentrate your urine to have a lower amount of urine output and maintain that water. So again, caused by a number of things. The treatment for it is actually fluid restriction, and you can also give salt tabs or a number of other different treatments. Hypervolemic hypernatremia, or hyponatremia, is more related to what I discussed earlier, so changes in water versus changes in sodium. So anything that can cause volume overload, CHF cirrhosis, and any kind of volume overload in CKD. There are then two other classifications that are unique to hyponatremia. So pseudo-hyponatremia can be caused by excess amounts of protein or lipids in your blood. This has to do with affecting the way that the lab test works. It alters the way that they dilute the blood, and so it's simply a false hyponatremia caused by a change in the way that the lab test works. Hyperglycemic hyponatremia is sometimes put in there with pseudo-hyponatremia, but it's not the same exactly. So it doesn't affect the way the lab works. It affects how much sodium is in your blood versus how much is in your body. So because of a difference in osmolality, the glucose contributes more than it normally does to the osmolar gradient in your blood. And that causes more fluid to rush into your blood, and the sodium to move out of your blood into that extracellular or the extravascular space. It can be intracellular. And so your sodium doesn't change. The total body sodium doesn't change. However, the serum sodium does change. And so as we reviewed in our lecture recording, there's a correction formula that you do. So your symptoms are listed here. Really, this is acute hyponatremia symptoms. I've seen patients with sodiums of less than 100 before, very rarely, who, because it's a chronic issue, are awake and not alert per se, but awake enough to be able to talk to you, which is nearly impossible in a case of acute hyponatremia, because you see around 110 or 115 is where seizure, coma, and death really start to set in. So the treatment, again, hypovolemic, you want to replace the volume, discontinue diuretic if that's the cause. And by replacing the volume with the appropriate fluid, you'll replace the saline as well. Usually this doesn't require rapid correction because usually it's a chronic issue. Euvolemic we talked about, either sodium chloride tabs or urea tablets, which can help reduce the reabsorption of water. And then you can also inhibit that activity of vasopressin. You can either use a Vaptan or you can use demeclocycline, which acts similarly to the Vaptans as a vasopressin antagonist. In hypervolemic hyponatremia, loop diuretics. So restrict fluid, restrict sodium, and get that extra fluid off. So ultimately you want to correct the cause here, not just focus on the sodium as an issue. Because if you give normal saline in this case, if you give IV fluid with sodium, you're actually going to worsen the situation, not make it better. And then remember, there's some formulas on here so you can predict what your change in serum sodium would be. This is if you use hypertonic saline. Hypertonic 3% saline is reserved for cases of severe symptomatic, potentially life-threatening hyponatremia, so it shouldn't be used very often. You may use diuretics to help get some water off. That will enhance the effects of the hypertonic saline because essentially you're removing water, so you're concentrating the sodium in the body and you're adding additional sodium. Your goal for correction as a general rule should be don't increase your sodium by more than 10 to 12 milliequivalents in 24 hours. So the risk here is osmotic demyelination syndrome. That is a potentially very severe, and the worst case that can happen is what we used to call it, which is CPM. So if you have demyelination of the neurons in your pons, which is what CPM stands for, central pontine myelinolysis, then the worst case scenario of rapid correction of sodium can occur, which is lock-in syndrome. So essentially the patient is completely awake, completely alert, but unable to move any part of their body. They can't talk, they can't think, and they can only blink. So that is a very rare but very severe side effect of rapid correction of sodium, and it's one that should stick in your head because it's one that we should prevent at all, if at all possible.
Can I ask you a question about the hypervolemic hyponatremia?
You can.
Is this the one that happens to alcoholics over time when their liver disease gets bad?
So if their hyponatremia is related to cirrhosis, that would be hypervolemic. But usually, so the one I would imagine you're thinking of is called beer potomania. And it's a euvolemic hyponatremia caused by basically when you consume all your calories through beer. Beer is not a very high osmolar fluid. So you're essentially consuming lots of fluid without any electrolytes in it. So you end up not with a hypervolemic hyponatremia, but a euvolemic hyponatremia. Does that answer your question?
Yes, thanks so much.
All right. So hypernatremia is categorized in similar ways, and remember, it's similar issues. So often, the most common causes of this are fluid-related. So in hypovolemic hypernatremia, again, total body water loss, which exceeds your sodium loss. So impaired thirst, inability to access water, can also be caused by diarrhea or osmotic diuresis, which is interesting, right? Because we can either have hypernatremia caused by diuresis or diarrhea, or hyponatremia caused by the same, right? So it just depends on how much of the electrolytes are lost in your fluid compared with how much is free water. So difficult to think about, but it simply has to do with the ratio of free fluid that you're losing compared with the electrolyte content. In euvolemic hypernatremia, it's similar to the hyponatremia version, so diabetes insipidus would be your big cause here, and it is essentially the opposite of SIADH. So it can be either central diabetes insipidus, where you're not releasing ADH from your pituitary gland, or it can be nephrogenic diabetes insipidus, where you are releasing ADH, but for some reason, often genetic, it's not having any effect on your kidney. So it's not doing what it's supposed to do. It's not able to act at the site of action. The treatment for central diabetes insipidus is to give ADH. So in our case, that would be desmopressin. The treatment for nephrogenic diabetes insipidus is extremely odd and way beyond the scope of this class. And I don't fully understand why it works. I just know what it is. So if you want to email me about it, I'll be happy to talk to you about it, but it's very strange and I don't think worth knowing at this point. For hypervolemic hypernatremia, this is usually iatrogenic. So if we give normal saline to a patient at a high rate for a very long time, you're going to have too much fluid and you're going to have too high of a sodium content. It can, in some cases, there's been several cases before that case reports have been written about where someone drinks just soy sauce on the dare. So essentially, any hypervolemic hypernatremia can be you drank or were given fluid with a really high sodium content and too much of it. The symptoms of this, once again, are neurological. They become more severe the higher you go, just like with hypernatremia, the severity increases the lower you go. And if it's chronic, it will take a lot longer to reach the later degree of symptoms compared with acute hypernatremia. So once again, treatment follows sort of a similar but opposite idea to that of hyponatremia. So in hypovolemic hypernatremia, first you want to restore intravascular volume with normal saline, and then you can correct the water deficit. So even though normal saline has 154 milliequivalents per liter of sodium in it, so it doesn't sound like your ideal treatment for someone with high sodium. Simply restoring intravascular volume will bring your sodium down because you're still diluting out the sodium. And the original issue was a concentrational effect. So your goal for correction, very similar to hyponatremia. And the reason this case is not ODS, it's related to cerebral edema. So rapid correction of hypernatremia results in cerebral edema. Worst case here is that you can have a brainstem herniation and your patient dies. So again, similar severity, but a different cause. Euvolemic, we talked about this, so central diabetes insipidus, desmopressin, nephrogenic, a combination of thiazides, amiloride, and indomethacin. Not sure why it works, but it works. Hypervolemic hyponatremia, you give loop diuretics to help diurese. However, the diuresis is better at getting water off than getting sodium off. So you also want to give B5 to help replenish the water that you're getting rid of without replenishing the sodium that you're trying to get rid of. So on to potassium disorders. Potassium, as opposed to sodium, is more of an intracellular cation. It's involved in a number of cellular processes and is eliminated primarily by the kidneys. So causes of low potassium can be, again, excessive diuresis or GI losses, and intracellular shifts caused by a number of things. So increased pH, insulin activity, and beta-2 agonists can cause this. And incidentally, those are three things that we use to treat hyperkalemia. So they're important to know. Refeeding syndrome can cause hypokalemia, as we talked about in our nutrition lecture. Hypomagnesemia is also important, and if you have concurrent hypokalemia and hypomagnesemia, because of the way that your kidneys work in resorbing potassium, you have to correct the magnesium first if you're going to correct a patient's potassium. Symptoms are muscular in nature, so skeletal muscle symptoms as well as cardiac muscle symptoms. And obviously, to cure the cardiac muscular symptoms are the ones that you're most concerned with, as those can cause arrhythmias and potentially be fatal if they're severe. Treatment is potassium replacement. So if the patient's not symptomatic, give oral replacement because it is less urgent. However, you do have to divide it up so that you can avoid all of the GI side effects that come with potassium replacement. If the hypokalemia is very severe, so less than 2.5, or the patient is symptomatic, or they're not able to tolerate the oral potassium, then you can give it intravenously. So typically, we don't exceed a rate of 10 milliequivalents per hour, and the concentration depends on whether or not the patient has a central line. So 20 milliequivalents per 100 mils is okay in a central line, but it will probably burn in a peripheral line, so we reduce it to 10 milliequivalents per 100 mils. And then, again, as I said, you correct the hypomagnesemia if that's present. So just a summary of your oral potassium products. It's useful for reference, not useful to spend a whole lot of time simply studying for. Hyperkalemia, most commonly can be caused by overcorrection, but renal failure is another major cause, particularly severe acute renal failure or patients who are non-compliant with their dialysis. Again, extracellular shifts can cause it, so acidosis. In this case, it's very common in DKA because you have a combination of insulin deficiency and severe acidosis. And decreased aldosterone effect, as well as certain meds, some of which affect the aldosterone and some of which inhibit potassium excretion. So your symptoms, once again, are muscular. The typical cardiac symptom that you think of, aside from actual arrhythmias, is peaked T waves on an EKG. If you see peaked T waves on an EKG, then you should take that as a sign that the patient has severe hyperkalemia. And in that case, under severe, you'll see the first medication that you want to give is IV calcium. Calcium does not affect potassium levels in your blood in any way. You will be asked that when you're on rotations. Do not be tricked by it. Doesn't change potassium levels. It antagonizes the effect of potassium on the cardiac membrane. So IV calcium and potassium have contradicting effects on the cardiac membrane. That's why we give IV calcium. So you'll hear people describe it as stabilizing the cardiac membrane. In cases of severe hyperkalemia, after you give calcium, you want to move potassium into cells. So like I referred to earlier, in hypokalemia, there's a number of ways we can do it. Insulin will move it intracellularly. Sodium bicarbonate can induce an alkaline environment and move it intracellularly. And then less commonly, albuterol can be used as a beta-2 agonist to move the potassium intracellularly. Albuterol requires high doses, and one of the effects of high-dose albuterol is cardiac side effects, right? So palpitations. So you can see in hyperkalemia, where we're worried about cardiac effects, why maybe albuterol is not used quite as frequently as the other two. Insulin and sodium bicarb will see a fair amount in clinical practice. And I have that little note there. So unless the patient's already hyperglycemic, you generally do want to give dextrose before you give the insulin, because obviously this can also cause hypoglycemia. So this does change your serum potassium levels, but it doesn't change your whole body potassium levels, right? We're just moving it away, which is a temporary fix, which maybe lasts an hour or two. So in order to ultimately fix the issue, we can remove the excess potassium from the body. So a loop diuretic, normally a furosemide, a cation exchange resin, so that would be Electrolytes, which is sodium polystyrene, or more commonly now we have a new agent called Veltassa, so the brand name of that is Patiromer. It's better tolerated than Electrolytes. It's actually cheaper on a day-to-day basis, so a single dose is more expensive than a single dose of Electrolytes. But if a patient has to chronically be on this, 3 doses of Electrolyte a day is more expensive than 1 dose of Patiromer a day. And then dialysis is an option as well. In this case, generally dialysis is only used in patients who have hyperkalemia because of noncompliance with dialysis. Because if you're trying to remove potassium from a body, 1, you don't want to undergo the infection risk of establishing the dialysis line when you can give a simple medication. And 2, it takes a really long time to do, even if you did want to go that route. All right, does anyone have questions about sodium or potassium disorders? All right, hearing none, we will go on to the cases. So there are 2 today. The first case is a 56-year-old female with a 50-pack beer smoking history, admitted for a COPD exacerbation. Her past medical history is listed. Her electrolytes are generally normal with the exception of an elevated potassium level, and she also has an elevated serum creatinine. ABG is listed there, so her pH is 7.2, and her PCO2 is elevated as well, and her bicarbonate is down. The whole meds are listed here, and then there are no signs of hyperkalemia. There are no peak T waves on an EKG. So let's let's go through. And before I start this, I am hopeful that you had an answer to the acid base. I also understand that's your next topic, but it's relevant to this because acid base status can significantly affect your electrolyte status. So if we have to talk it through, we'll talk it through. But let's give it a shot. So starting out, what therapeutic plan would be most appropriate in this setting? Hopefully what you inferred from that was regarding the hyperkalemia. So we will go to group 5 in Athens. What therapeutic plan is most appropriate in this setting?
We said since the patient is hyperkalemic but does not have any clinical signs that we would do a loop diuretic alone.
Okay. Beautiful. Which one would you pick?
Lasix 40.
Okay. Did you come up with a dose?
40 IV.
Okay, perfect. So we're in luck. We came up with the same answer. So furosemide, 40 milligrams, given intravenously. 40 milligrams is a standard dose. Sometimes people will give 20, sometimes they'll give 80. I don't really see any need to waver from the 40 unless you don't get the desired therapeutic effect. As group 5 said for us, this is appropriate because the patient is asymptomatic, so there's no need for urgent changes. There's no need for urgent correction. There's no EKG changes. However, we do want to give it IV to make sure that we do get the desired effect in a somewhat timely manner. So we'll move on. So what is the acid-base status? What is the acid-base disorder we've got going on here? And how would you recommend treating that? We will do group 22 in Albany.
Respiratory acidosis and treat with bronchodilators.
Perfect. So the patient came in with a COPD exacerbation, right? How do we want to help them breathe better? They have a respiratory acidosis because of accumulation of carbon dioxide. We want to give them bronchodilators in order to help them breathe better. Very straightforward, very simple. Why does this matter? Because, as we discussed before, part of your risk factors regarding potassium are that an acidic environment can increase your hyperkalemia. So as we correct our acid-base status, not only do we want to fix the potassium, but we also know as we fix acidosis, our potassium will go down as well. What medication therapy issues are present in this patient, and how would you go about fixing those? So we will go to group 19 in Athens for that. Or sorry, that's Augusta. Group 19 in Augusta.
We can increase HCTZ to 50 milligrams POQ day, and also just watch the potassium levels as we fix the acidosis.
Okay, good. So potentially one option would be to increase the dose of the diuretic. Did you identify any medications on the patient's home meds that could increase risk of hyperkalemia?
The lisinopril.
Good, so lisinopril. So what's the cause of the AKI? So we need to address that. And then the hypertension meds, namely the lisinopril, increases your risk of hyperkalemia. And certainly hydrochlorothiazide could potentially be increased if this is a perpetual issue. The lisinopril also increases the risk of acute kidney injury. So although it probably is not the inciting cause, it certainly could have been a cause that worsened it. And then lastly, for group 9 in Athens, what are some monitoring parameters that you would want to institute in this patient?
We said potassium levels, magnesium levels, EKG changes, and arterial blood gas.
Okay, perfect. So I got EKG, signs, symptoms, which is pretty much covered by EKG, I think. So we'll let that ride. Potassium, and then I also like that you said magnesium. I do not have that on here. However, I do think it's very appropriate to monitor your magnesium levels as well, although it's of more significance in a patient with hypovolemia, because that's the instance where it might be difficult to correct. Any questions on case 1? Cool. We'll move on to case 2. 22-year-old female admitted for diabetic ketoacidosis. Labs are listed here. Your vitals are listed here. What are your causes, your potential cause of hypernatremia? Tell me the reason, any correction you want to institute, and tell me how you would treat. So we will do group 24 here in Savannah. What is the cause of the hyponatremia? Is there any correction you would want to institute in that case?
We were thinking maybe dilutional hyponatremia from giving too much fluid in the DKA, because you normally give 1 to 2 liters, so maybe it's too much for the patient.
Okay. Anyone else have any thoughts?
Because of the hyperglycemia?
Okay, who am I talking to? What group?
23.
Okay, so what do you mean by the hyperglycemia?
The high blood sugar is pulling fluid into the blood, and the sodium is going out into the interstitial fluid.
Okay. So, is there any correction that you would like to do for the sodium?
Insulin?
I mean, from a calculation standpoint.
Then I don't know.
Okay. Anyone want to help them out?
Isn't it like where you do sodium equals the measured sodium plus?
You have to do it.
I'm sorry, I was talking to someone here today. Go ahead.
Let's do a sodium correction for glucose because of the osmotic alterations in the serum that the high glucose causes.
Okay. So what is the correction?
136.9.
I got 137.
Yeah.
Okay, that's a 137.
136.9 to go.
Disagree? Agree? Anyone else? Want to jump out on the limb here?
Is it not right? That's what I heard.
We got similar numbers here. Let's talk about it. So remember that the formula that we use to correct for this is essentially for every 100 over 100 that the blood glucose is, you add 2 to the serum sodium. Right? So the formula is listed there. So if you think more mathematically, there you go. But if you think verbally, for every 100 over 100 that your blood glucose is, add 2 to your serum sodium. So 1032 minus 100 is 932. So that's approximately 9, quote, 100ths over 100. Then you want to add 2 for every 2. So you add 18 and a little bit of change. In this case, 141, which is very close to the 137 that I heard. This is important. Sorry, go ahead.
Where was this equation at? Was it in the slides?
Yes.
What slide number?
I do not know. If you will email me after class, I will go through my slides and find it.
Are there multiple ways to calculate corrected sodium? Because I found a different equation online and that gave me the 137.
There's about 1,000 different ways to calculate it. Yeah. Some people say add 1.6 for every 100. Some people say add 2.4. I like 2 because it's easy to remember. Some people say for every 100 over 200. Some people say for every 100 over 100. So the point, as with many things in nutrition and electrolytes, are that what you're doing is trying to estimate a reality, right? So there's a lot of variables that a simple equation can't take into account for. So all I want to know is this patient approximately normonutremic, if you will? Do they have approximately a normal sodium? As you correct it, you will see what the true sodium is. But if the patient comes in with a sodium of 122 and you start just loading down with normal saline, and then you give them insulin as well and correct their glucose, and lo and behold, you find that all of a sudden their sodium is 150. Well, part of that could be because you thought that they were hyponatremic, when in reality they were not. So the short answer is yes, there's a lot of different ways to correct sodium. The important thing is, especially for clinical practice, pick one and understand the concept behind the equation. Anyone have more questions so far? Yeah, so I was asked here to repeat the verbal explanation of the equation. So my verbal explanation is for every 100 over 100 that the blood glucose is, you add 2 to the serum sodium. And then the mathematical way of thinking about that is listed here. But know the concept. Anyone have questions? Please feel free to ask if you don't understand, because this becomes very, very important when you treat patients with diabetic ketoacidosis or hyperglycemic hyperosmolar syndrome. Any severe hyperglycemia, this will be relevant. And it does happen a fair amount in clinical practice. And to add to that, the pharmacy is usually the ones helping people figure out the protocols for these cases and determining what fluid is appropriate to give. All right, so hearing none, I'm going to assume we're good. If you have questions, feel free to email me. So how would we like to treat this? Let's do group 11. How do you want to treat?
We would increase the sodium by 1.5 milliequivalents per liter per hour over the first 2 to 4 hours.
Okay. Does what we just talked about regarding sodium correction change your answer? So we have a corrected sodium of 141. We still consider hyponatremic?
So we're discussing, we're saying that, yeah, it's within relative to normal levels, we would treat the hypoglycemia and then check it again. Because the corrected level seems okay, but obviously whenever we finish treating hypoglycemia and get a true value, then we might be able to check it again.
Yep, so that is partly true, and that is the correct thought process. However, and did y'all tell me you had gone over DKA already? Yes? Okay, I'm seeing yes. So remember, even though insulin is an integral part of your treatment of DKA, the most important initial step in treating DKA is fluids, right? Why is that? Because they're extraordinarily dehydrated. So even though you're correct from a sodium standpoint, you don't have anything to correct, you still have a fluid issue. So would anyone like to venture a thought? Maybe start a discussion on how we want to broach that.
Would you give half normal saline?
I heard, here in Savannah, I heard when you give them lactated ringers, and then you said give them half normal saline. Let's combine those two answers. So we will give normal saline or lactated ringers, either one is acceptable, to restore euvolemia. So you want to give a good a fluid that is helpful in fluid resuscitation to give, so a balanced fluid of some sort will be better for fluid resuscitation than half normal. And then, once you've restored euvolemia, generally as part of the DKA protocol, you do see an ongoing infusion of fluid. So usually protocols will be some fluid at 250 mils an hour, which is pretty significant. So after we have given some bolus fluids, typically you will see half normal saline started in patients who have normal sodium, corrected sodium levels. This reduces the risk of hypernatremia. Does anyone have any questions with that? So a balanced fluid bolus to restore volume and then half normal to prevent hypernatremia.
Is he dehydrated because all the water went into his vasculature, not his cells?
So this patient is, in DKA in general, they'll be dehydrated for the same reason. Think of the symptoms of diabetes, right? The 3 polys: polyuria, polydipsia, polyphagia. So this patient has diabetes on overdrive, right? So part of that will involve urinary excretion of glucose, and along with that will come fluid. So that they'll have a far beyond normal amount of urine output, and because of that, they'll become dehydrated. Anyone else have questions or clarifications? With or without potassium. So remember in this case, even though the potassium is 5, you will generally start adding potassium to your IV fluids around a potassium level of 5. Because remember, you're giving a continuous supply of insulin to the patient at a fairly significant dose, and that will lead to hypokalemia if you don't give potassium to the patient. That is it. Those are our 2 cases. Does anyone have questions about these cases? Cases from Monday?
I have a question about case 1. Yes.
Okay, yeah.
Okay, so can you clarify what treatment option that we decided for B? I thought that you said discontinue lisinopril and then increases HCTZ. Is that what it is?
So discontinue lisinopril, or at least holding it in the acute case, I think is appropriate. I don't think you have to discontinue lisinopril, and I don't necessarily think that we would, but certainly in the acute situation while they're in the hospital, I would hold the lisinopril. The hydrochlorothiazide, the group that answered mentioned increasing that dose, although not necessarily inappropriate. It's not necessarily like the first thing that I would jump to, especially from an outpatient regimen. So my whole answer would be hold lisinopril while in the hospital.
Okay, thank you.
Welcome. Anyone else?
Okay, so let me
Mike. Did you use your mic?
On the test, will you expect us to know how to use the corrected sodium equation, or?
Oh
my God.
Yes. I did. Anyone else? I got the question, how do you identify diabetes insipidus? So it generally is a long process. So one, you don't need to know how to do this. But it involves testing of like urinary electrolytes, evaluating patients who have hypernatremia, so you have to rule out other causes of it. In the case of central diabetes insipidus, you can give desmopressin as a test dose and see if it works. If it doesn't work, you know it's it's really only helpful if you think it's central diabetes. If it works, you know you have it. If it doesn't work, you either have nephrogenic or you don't have it at all. So it's kind of a long, complicated process to answer your question, but it involves ruling out other causes, using urinary electrolytes to evaluate whether or not sodium is being excreted as it should be, because in a high hypernatremia, you would expect your urine to have a high amount of sodium, right? Because your body wants to get rid of it. So if it's not, you know that there's an issue with your kidneys. And then you go down the trail of diagnosis using desmopressin and so on. You will absolutely not have a case like that. Any other questions?
I did have one more question. Is the only time we need to correct the sodium when the patient's hyperglycemic, or are there other instances where we would need to do that?
That's the only time, when they're hyperglycemic.
Thank you.
I have one too.
Okay.
Probably like super dumb, but I don't know the answer.
Okay.
How do you know if they are hyper or hypovolemic? Like, is there a lab value that we look at for that? This one specifically?
There's some lab values you can look at. Part of it's based on clinical assessment. In DKA, assume that they're hypovolemic, right? If you have causes that seem obvious, then go in that direction. So if the patient is on like 80 milligrams of Lasix 3 times a day, and they come in with hyponatremia, I'm pretty much going to go in the direction of Lasix starting out. Lab values that you can look at, so normally in a eubulemic patient, you have your ratio of BUN to serum creatinine is between 10 and 20 to 1. So if your serum creatinine is 1.0, your BUN should be between 10 and 20. The ratio of those two. If you have a serum creatinine of 1 and your BUN is 30, sometimes that is caused by hypovolemia, so dehydration. You can look at acute kidney injury as potentially being caused by that. It's not always caused by dehydration. There's a number of causes. Blood pressure can be related to that, especially if they're tachycardic. So there's a number of maybes to that answer, but there's not one sure shot from a lab standpoint. Again, remember, so I want you to know this, but I also know the urgency of studying for a test when you're a student. So if there's a lot of cloudiness surrounding clinical assessment on a patient, you're probably not going to have an answer or a question about it unless I make it clear for you. And if you have an issue with a question, then complain about it. And if I realize it's unclear, then we'll throw it out.
Okay, your words, not mine.
Anyone else? Okay, I have a list of 10 things that you should know for your life and the test. Anyone else know those? A resounding yes.
That's a yes from Augustus, sir.
Yes from Augustus. I love it. All right, so here we go. Things to know for the test. I told you some disease state specific formulations for nutrition that you needed to know, right? Examples of that included low carbs and diabetes, certain types of amino acids and liver failure. So know disease state specific preferences in nutrition. Please know interactions between drugs and enteral nutrition, so that's like feeding tube things, and how to manage them, right? The example I gave was, for example, with quinolone antibiotics, you need to know that they bind with multivalent cations. Warfarin has some nutrient interactions. There are tube administration issues with drugs. Phenytoin is one, requiring holding of tube feeds. I described that in the lecture. Make sure you know those. Make sure you know how to calculate kcal and protein requirements. Right? So acuity of illness was part of that. It'll be obvious what their acuity of illness was. I gave you some guidelines. Severe is ICU, moderate is hospitalized.
That goes with that.
Kcal requirements are not that complicated. Harris Benedict's formula is 25 to 35 kcals per kilo. So know which body weight to use as well. Number 4 is the complications associated with enteral, parenteral, and both. Along with kcal and protein requirements, you need to know fluid requirements. You need to know lab monitoring of nutritional status. So remember, we talked about the way that you monitor protein status in particular. There's one that's preferred, and there's one that can change that. We talked about the relationship of albumin, prealbumin, and CRP. We talked about calculating lipid requirements, drugs that come in lipid emulsions, and how they affect your lipid calculations. Talked about that. You need to know how many kcals per gram each macronutrient supplies. And then you need to know the electrolyte things that we discussed today. And actually, the question I got earlier about knowing how to correct sodium for hyperglycemia, you actually don't need to know that. That was a lie. But you do need to know how to treat hyponatremia. You need to know how to correct hypo and hyponatremia. Talking rates here. Know your maxes. Know the complications if you exceed your maxes. And then lastly, you need to know treatment for hyperkalemia like the back of your hand. 3 classes of things that you do, right? You stabilize the membrane, you move potassium intracellularly, and get rid of it. Get it out of the body. And the reason I tell you these things is 1, because I was a student 3 years ago and I get it. But 2, because not only are these the things that we're testing you on, but these are the most important things for you to know moving into rotation. I want you to have this baseline and then add to it on rotations. So know this stuff. Does anyone have questions about that? There's a lot of material to study, but it is all important. Sorry, go ahead.
Sorry, for the body weight thing, we've been taught like 20% and 30% over and stuff, so like which do you use?
So for TPNs, so nutrition, the rules are a little bit different than pretty much, in my clinical practice, in fact, enteral and parenteral nutrition have different ideal and adjusted body weight rules that I use for other drug calculations. For enteral nutrition, use actual if they're under their ideal. Use ideal if they're not obese, and then the obese is at 30% over their ideal body weight. So once they exceed 30% of their ideal body weight, use a 25% adjusted body weight, not a 40% adjusted body weight. That is unique to nutrition.
Would you mind repeating that?
Yep. All of it are just the adjusted part.
All of it, if you don't mind.
All of it. All right, so if they're underweight, use actual. Underweight means less than their ideal. If they're, quote, normal weight, quote unquote, which means between ideal body weight and 1.3 times ideal body weight, so 30% of it, use ideal. If they're overweight, use adjusted. Overweight is defined as more than 30% of your ideal body weight. Adjusted is defined as a 25% adjusted body weight. And that should be on your slides too, if you didn't catch that. I hope. Anyone else? All good? All right, thank you everyone for great questions and paying attention, I hope, at least most of you. And I wish you the best.